Hello, everyone. Today, I'd like to welcome you to a special edition of the MCHD Paramedic Podcast that really isn't the MCHD Paramedic Podcast. I was lucky enough to be invited to join Ginger Locke on the Medic Mindset Podcast, and she was gracious enough to share the audio with us here at MCHD. So we're releasing an episode of the Medic Mindset Podcast here on the MCHD Paramedic Podcast. Ginger and I discussed rate control and rapid atrial fibrillation with a specific focus on diltiazem. Ginger is an absolute master podcaster and pulled some really amazing conversation out. We discussed some literature. We discussed some practical thinking approaches to dealing with these patients. And honestly, I'm very proud of how this episode turned out and happy to share it with you here on our platform. So please, wherever you listen to your podcast, like, subscribe, spend some time listening to the Medic Mindset Podcast. Ginger is an absolute master, and you can't go wrong listening to any of her content. Without further delay, here's our discussion on atrial fibrillation, diltiazem, and how we deal with AFib with RVR in the EMS setting.
This episode of Medic Mindset is supported by iSimulate. From the very beginnings of this podcast, I've been committed to keeping Medic Mindset always and forever free. Their support allows me to do that. Thank you, iSimulate.
The act of standing and watching that sick patient and being unsure what to do, which is a natural response. That's not a knock at the paramedic that gets locked up. That's not a knock at the ER doc that gets locked up. I've been locked up plenty of times in my practice. What you have to work past is, what measures can I put into place to buy me time? We chose the profession where we arrive at the edge of compensation. And sometimes that means operating with less than a full deck of cards. And that's just, it's not bad, good, wrong, or right. It just is part of what we do. So we have to prepare for that in our thought process. There should be a 2-hour limit before you can give diltiazem or rate control in the emergency department. I want to limit myself and my emergency department partners. This is not a paramedic limitation that I'm talking about. We need time to sort out these patients and decide, is the rate the primary problem, or is the rate and the tachycardia a result of a secondary illness?
Welcome to Medic Mindset. I'm Ginger Locke. Like all episodes of the Thinking series, this episode will be available for CE at prodigyems.com. Our guest is Dr. Casey Patrick, who's the medical director of Montgomery County Hospital District in Texas. And if you're into podcasts, I highly recommend his. It's called MCHD Paramedic Podcast, and it was started in 2018 and has amassed 177 episodes to date. It's clinically rich, very comprehensive, and also has a bank of episodes available for CE at Prodigy. Our topic is rapid AFib, and I contacted him about this particular topic because I've seen some consistent cognitive tripping points there. I wanted to illuminate these in our discussion and hear his thoughts on it. And interestingly, he's seen the same in both his practice as an EMS medical director and as an EM physician. What you're about to hear is a person who thinks deeply about his own decision-making and takes steps to mitigate flaws in his own thinking. You will hear him turn to research, talk about contacting colleagues, using metacognition and humility to carefully reflect on his thinking and decision-making. This episode is a masterclass on how to think about one's own thinking. Originally recorded in 2021, all of the information still held, except for he wanted to add in one bit of research that's come out about diltiazem since we last spoke, so you'll hear that get spliced in during the episode. Let's listen in. What is unstable to you? When we're talking about dysrhythmias, what's unstable?
First and foremost, you have to look and think about whether or not the rhythm is the primary problem. And that's where the difficulty comes in. So the patient's history, the course, the acuity of the onset all come into play. So has the symptoms, did they develop acutely? Was this been in the past 20 minutes, the past hour? In that situation, if you're staring at a tachycardia, whether wide or narrow, your focus probably should be on that rhythm. If the patient's been slowly deteriorating over days, weeks, then you're probably looking at a more subacute process with the cardiac rhythm being secondary to the underlying illness, whether that's DKA, pulmonary embolus, dehydration, sepsis, any of the possibilities there. Instability is going to be defined by the patient's history. How long had they been sick? How acute was it? And then obviously we always look at vital signs, and most protocols out there have a blood pressure cutoff for unstable tachycardias, narrow or wide. But that's also just a number as well. Is the patient perfusing? Are they mentating? Do they have normal skin color? Are they diaphoretic? Are they vomiting? Are they mentating, normally answering questions? I'm much less likely to cardiovert or fibrillate a patient that's awake and alert and talking to me.
Right.
That doesn't mean I'm not concerned. That doesn't mean I don't cast out a wide safety net of resuscitation and monitoring and all the things that come along with it. But really, the ones that get confusing are the ones where the symptoms are vague and the timing is vague, and we see a tachycardia. I always make sure that I say this anytime I'm talking to my medics at MCHD, say it to the listeners. I'm not a paramedic, never been one. So I don't like to veer into the range of hypocrisy. It's something I try to avoid. In my practice as an emergency physician, I always have more information than the paramedic does because I have your information that you give me on changeover. It's important to remember that the medics out there are encountering these folks with very little. And sometimes the patients have good history. Sometimes they're scared. Sometimes they're sick. Sometimes they don't have the medical knowledge that we have. Oftentimes they don't. We have to remember that we're operating in a black box, especially in the EMS pre-hospital world, because these patients are complex. Diagnosing a PE takes a couple of hours for me in the emergency department. So putting it on the differential list for a medic is tough because we don't have a CT scan with contrast and D-dimers and really time. Right. So it's going to be mentation, it's going to be blood pressure, and a combination of acuity, I think would be the three things to summarize that into a short bit is did this occur abruptly? Are they altered? Are they hypotensive? Signs of poor perfusion. And in those situations, I think that we're in the unstable range. Not to speak specifically to anyone's protocols out there because there's going to be varying levels of MAP and systolics and other definitions. So always operate under your protocols, but that will be my overarching answer.
And I expected you to say hypotension, and I expected, and you did, and I expected you to say level of consciousness, and you did. And then the piece that you filled in for me that I haven't spent enough time thinking about is this idea of, did it happen abruptly?
I don't have an evidence-based answer for that, but it would be odd for you to sit around with an unstable, let's do wide complex, unstable VT for a week.
Yeah.
That would be a bit odd, I think. I think most clinicians and cardiologists, emergency physicians, paramedic educators out there, I think most people would agree with that. So none of these things are ever hard and fast. These are really complex patients oftentimes. I think when you try to put a single rule on a complex process, it tends to fail.
Yeah.
So that's just a piece of the puzzle. I think most of the time these are going to be acute, or at least that can be. If it is acute, it should point us more towards that rhythm being the underlying cause. And that's really the hard piece of the puzzle, is trying to determine whether the rhythm you see is the cause of the patient's problems. And if it is, that should be the primary thing that you address. That's the gist of the whole discussion, really.
And to your point earlier about paramedics and out-of-hospital medicine, they're working from scratch. If this is an unstable patient, by definition, they're not going to be highly communicative.
No.
To get that history without family there or someone else to tell you that, or some scene clues, you have this list of 3 things, you may never be able to get that data point about how quickly this evolved.
And that's part of the push in medicine. I was trained to write things like poor historian in the chart. Well, it's not that the patient's a poor historian in this situation. It's that they're scared and their MAP is 45 and their brain's not perfusing. So it's not that they're a poor historian. It's that they're in shock and they can't process your questions and can't give you solid answers. So it may not be an issue of them not wanting to give you the answer. They just can't. And then their husband or wife or significant other, whoever's with them, son or daughter, they're scared because their loved one is in shock. Mm-hmm. Of course, they're not thinking clearly as well. Mm-hmm. So we chose the profession where we arrive at the edge of compensation. And sometimes that means operating with less than a full deck of cards. And that's just, it's not bad, good, wrong, or right. It just is part of what we do. So we have to prepare for that in our thought process.
Going back to this idea of poor historian, someone made the point. They said, the historian is the person collecting the information. Like, we're the poor historians. It's on us to gather all that story, and we work with what we've got.
And honestly, in these situations for us as providers, we have to act without history. Medics I work with get sick of me saying it, but the worst thing you can do with an unstable patient is nothing.
Mm-hmm.
So you just have to say, for whatever reason it is, whether it's poor perfusion, whether it's intoxication, whether it's, shock, hypoxia, hypothermia, whatever the reason is that the patient cannot give you the information that you need. If they're hypotensive, hypoperfusing, hypercarbic, hypoxic, whatever it is, when we see those vital sign derangements, we have to be willing to move past those desired steps and get to the resuscitation. Mm-hmm. The worst thing we can do is say, well, I don't know how long this has been going on, or I don't know what meds they're on. Well, we got to be willing to say, we're not going to know. You got to give a good effort. You got to try to do a good scene size up, try to get the patient's family, the companion. You got to try to get some information, look for medical bracelets, all those things we talk about. But if we don't have them, we got to move past them to the non-rebreather, to the proper positioning, nasopharyngeal airway placement, just the good, solid resuscitation basics, because all that time that we do nothing is time that the patient can further decompensate.
And as far as our care plan, you're saying, we've got to make decisions. We've got to start something. I think the way most protocols are written, or the frame of a paramedic beginning treatment with limited info, is start with those treatments that have the fewest risks. Start with the stuff that you may not do further harm. And then by adding that treatment, you've poked at the system that now all this new data is going to come out, and it'll look a little different because you've agitated it a little bit.
Yeah, resuscitation's a movie. It's not a still frame picture. We've had these discussions within the clinical department. I've had this discussion on scenes and in the hospital parking lots about delayed sequence intubation. As an example, we've done so much work with the idea of resuscitation before intubation. Thank you, Scott Weingart. Thank you, Jeff Jarvis. Thank you for the folks out there that have laid this foundation. It expands out into patients like this, to tachycardic patients. We're not intubating them. We may, if they're an unstable VT that decompensates. But the idea of resuscitation before full information collection, however you want to phrase that, a resuscitation bundle is what I've arrived at in our services at this point, to bring it back earlier to the point of patient contact and say, yeah, putting a non-rebreather on that patient in the short term, you can go into hyperoxemia and downsides there. But in the short term, if you have a short of breath hypoxic patient, there's no harm there. Mm-hmm. Early access, no harm there. Mm-hmm. Proper positioning, airway adjuncts, full monitoring, waveform capnography in place, a blood glucose, suction prepped, push dose epinephrine prepped. None of these things have any real significant downsides. You start to get into fluids. That's where you really have to think a little bit more. Do you have an end-stage renal disease patient? Do you have an acute pulmonary edema patient? That could be detrimental. But a lot of the resuscitation bundle facets that we talk about are fairly harm-free. Nothing's harm-free, risk-free. But relative to what you can gain from that, how does the patient respond? And then you can work from some objective platform in that we put oxygen on and their mental status improved. Well, it declined. We see an end tidal and we can trend that. So in that movie of resuscitation, if our progression is to the positive, then maybe our non-invasive treatments are all that we need. If the patient sort of declares themselves that even with non-rebreather, a bag valve mask, a PEEP valve, head of bed raised, apneic oxygenation, suction, push dose, fluids, access, we have declining mentation, declining blood pressure, worsening end tidal, worsening oxygenation, then the movie is going to an unhappy ending, and it forces us even more into a position of action, I think.
I like that. I've never heard anybody talk about all this pre-resus stuff we do for DSI is really an approach for every high acuity patient.
I'm not sure that I have it entirely encapsulated into an easy elevator speech in my mind. This comes from 5 or 6 years of a lot of my job is oversight and chart review, and seeing both in my own practice in the emergency department the act of standing and watching that sick patient and being unsure what to do, which is a natural response. That's not a knock at the paramedic that gets locked up. That's not a knock at the ER doc that gets locked up. I've been locked up plenty of times in my practice. What you have to work past is, what measures can I put into place to buy me time while I'm collecting information? And the information that I can collect as an emergency physician is much, much more robust than what we can collect in the field as paramedics. But it shouldn't limit us to putting those into place and allowing the patient to progress or to regress. What I find is that so many times with the sick patients, we get, oh, this patient needs intubated, because that's an action that we can take. They may need to be intubated. They may need an iGel. They may need continued bag valve mask. They may need BiPAP. But the steps that we take to get to cardioversion, to get to sedation, the steps we take to get to airway management, the steps we take to get to, difficult extrications, to, rapid trauma transport. A lot of times those initial steps in that resuscitation bundle are very much the same. They are skills that the entire team can perform. These are EMTB, AMT, medic skills. So we can work as a team and multitask, perform these in parallel as opposed to in linear, and then make our decision as it progresses itself within that movie. We don't take a picture of the monitor and send that monitor picture to the ED to make their decision from. We bring a full patient that's progressed over the time that we've cared for them in the field.
Yeah, you were talking about chart review. One of the things I know both of us wanted to say at the beginning of this episode, because we're talking about rate control and AFib, is probably our central topic. We wanted to communicate that we are going to explore, when and how to rate control and, the risks of doing that. I think we both want to communicate that. I'm just going to say it may have a tone of like paramedics shouldn't be doing rate control and AFib, but the reality is it's because we know how hard it is to make that decision of, is the rate causing the problem or is the problem causing the rate?
Yeah, I made notes over the last couple of weeks thinking about this topic, and I get a lot of ideas when I'm out jogging. That's when my brain fires things back at me. So I end up running in the house, sweating over a Post-it note, writing bullet points. And last week, I really summarized this thought, because sometimes I can be pegged as hey, you're trying to limit our skills, medical director, I think. And this is absolutely not the case with diltiazem and rate control. For the listeners out there that have diltiazem in their protocols, please use your protocols, learn them, work with them as you're taught and directed by your medical direction and your clinical staff. I have to be honest with the listeners and say I don't have diltiazem in my protocols at my services, but I would say that if I could be the king of the world, the medicine world, and decree things from on high, I don't want that job, but if I had it, there should be a 2-hour limit before you can give diltiazem or rate control in the emergency department. I want to limit myself and my emergency department partners. This is not a paramedic limitation that I'm talking about. We need time to sort out these patients and decide just what we talked about earlier, and that is the rate the primary problem, or is the rate and the tachycardia a result of a secondary illness? It's hard, if not impossible, for paramedics with zero time, minimal diagnostics, and oftentimes incomplete histories. It's also hard for emergency physicians, for intensivists, for folks in the hospital. That's after a bedside echo, a chest x-ray, metabolic panel, troponins, repeat EKGs, improved history because I have medical records. I see folks with COPD exacerbations, with PEs, with dehydration, getting rate control inappropriately in the emergency department all the time. I'm guilty of it. Limiting it in the protocols from an EMS standpoint under my medical direction is just purely out of patient safety and the fact that it's just too difficult for us to discern. I would limit it in EDs if I could. So hopefully that is a clear way of saying that this is not some situation where paramedics can't recognize atrial fibrillation. We absolutely can. Paramedics can't treat the patient as appropriately and effectively as the emergency physician. That's not it either. I put us all in the same boat here, that we need a fairly extended amount of time to decide, and to accurately decide, I should say, whether rate control is the primary treatment modality that we should shoot for, as opposed to resuscitation for dehydration, DKA, PE, sepsis, obstructive lung disease exacerbation, right on down the long list of other things that can cause neurocomplex tachycardias secondarily. For the listeners there, for the services that I work with have, relative to most EMS, short transport times, good access to urban STEMI centers and stroke centers. I'm not in a rural environment where we have 2-hour-long transports. I'm not a medical director for any helicopter EMS services, so I'm talking ground-based, 911, for the most part, short transport times. If you're in Western Australia and you're flying out of Perth to get somebody 4 hours away, a diltiazem drip may be the right move. And my mind might change if I have my patients for longer, if my medics have patients for longer.
I have so many thoughts as you're talking. Let's go to the 2-hour frame that you've given us. That's really concrete and tangible. What it says to me, just as a listener, you're saying people in AFib, fast AFib, they have a little time. Even if that's the primary cause, they have a little time for us to make sure.
That's where the stable, unstable comes into play. This line of conversation, let's, for discussion's sake, say we're talking entirely about stable AFib, A-flutter.
Mm-hmm.
Yes, they do. They're stable. There's lots of evidence out there that says that even when we rate control them within 24 hours, oftentimes they're back in neurocomplex tachycardia. So what I think this stems from, both from an emergency physician standpoint and a paramedic standpoint, is that we have a very clear objective finding. For sure, in the world of a paramedic, we don't have tons of objective findings. We're dealing with lots of incomplete and lots of subjective. Emergency physician, get the changeover from the medic. I don't have my labs back. I don't have my x-ray. Maybe I've got a bedside ultrasound. Hopefully I'm using point-of-care ultrasound. You see the number and the morphology, even on the 3-lead on the monitor, and it's just something that you can focus on and you can fix. And that's what we all like to do, is fix things. But we have to back away from that instinct and say, is fixing this going to cause more harm than good, potentially? Is fixing this necessary right now? Because to get a diagnosis of sepsis, I need other pieces of the puzzle. We may suspect it based on acute SOFA score or, insert your SIRS or whatever criteria you use. DKA, I'm going to need a metabolic panel. COPD, we should be well on our way to COPD, even in the pre-hospital setting with waveform capnography and an exam. But sometimes it's not that clear. Pulmonary embolus, I need a CT scan. It's going to take a couple hours. Dehydration, I need a metabolic panel. If you've got, a heat stroke situation, that probably should be, clear in that COPD range. But sometimes those patients are really difficult to sort out because they may not be the obvious Ironman participant. It may be a nursing home patient. Those can be really, really murky too when they're not, an athletic overexertional type heat stroke. And then you have all of the toxidromes that we take care of, the sympathomimetic toxidromes, specifically meth, PCP, cocaine, crack, all of those that can be interspersed with every other diagnosis that we talked about, because patients don't always have one thing. They can have toxins on top of other medical illnesses. To me, all of those things are not straightforward and easy from a diagnostic standpoint, especially when they occur together. So that 2 hours really is just sort of that 120 minutes it takes me to get my ED workup back. Now that's assuming that I have a waiting room that's tolerable and there's not 2-hour wall times and all the things that we've been dealing with over the past couple of years with COVID and the pandemic. But 2 hours is a random number that I pulled out of the air to say, I need my diagnostics and all my emergency testing back before I can really pull that trigger. That's me and my practice. So if I feel that's where I should end up, that's appropriate for the medics and my services as well.
What you're doing during those 2 hours is continuing to be with the patient, right? There's someone that's they're not being ignored. And should they trend a certain way or start moving from stable to unstable, then you may have to change that time frame.
Yeah, they need to be on the monitor, pads likely, repeat vital signs, repeat EKGs, potentially electrolyte replacement during that time. If you've got a patient that you think's wheezing, you're going to be using, whether or not you use albuterol or Xopenex and you're in the hospital and you have access to Xopenex, you think, well, maybe little less chronotropy is a good thing there. There's lots of other things. You may be doing a fluid bolus if you think the patient's dehydrated or DKA at the same time, and watch the trend. If you think, is this AFib flutter or is this sinus tach? Is this multifocal atrial tachycardia? In those situations, the treatment is resuscitation. Sometimes in AFib flutter, the treatment is resuscitation. It's just a response to that underlying illness. So that goes back to it being resuscitation's a movie, both in the pre-hospital setting and in the ED setting. We get the benefit of watching how the patient progresses. And that cannot be underappreciated or underrated. Just because you can do something doesn't mean you should do it. Just because you might need to do something, does it have to happen emergently, urgently? Can you put it on your list and say, well, if our labs push us a certain way, if our x-ray and our point of care ultrasound points us certain ways, then yeah, we'll get the diltiazem out, or, the beta blocker or whatever you choose to use.
I was glad you brought up heat stroke, because this wasn't an AFib patient I had, but I've been real transparent about this before on the show, is that I misdiagnosed a heat stroke because it was a sinus tach at rate of 194 and missed the heat stroke, right? Because the monitor got on early, just like you said, right? We're slow to get a temp. See that rate, 194, narrow complex tachycardia. He looks unstable. And I think that's important to talk about unstable. People can be unresponsive, but not because their blood pressure's low.
No, and not because they're tachycardic. They can be tachycardic because their heat dissipation mechanisms are broken if they're on a beta blocker or on antihistamines, or they're unable to get out of the heat if they're in an exertional setting. But the first thing that you saw was 194. And any provider is going to absolutely latch on to that. That's what any of us would do. What we have to be able to do at some point during that progression, and if I see 194, I'm getting an EKG straight away. It's not that I'm not going to act on that, but we have to remember that there are, like you said, other causes for 194, and it could be heat, it could be toxins, it could be dehydration, it could be cardiac. We just can't close that diagnostic door before we collect all the information and all the history. And that's sort of that, we get biased by the first objective thing that we see. And it's really easy for us to focus on that, monitor heart rate, and then get that EKG, and then go right down the one-way path to that's the only thing it could possibly be, because that's the one thing that we can see. And that's not, it's just not unexpected. I've sat with so many medics and, beating themselves up over cases like this. And if you only had the EKG, why would you not think that was potentially the cause? It just can't close the door with one diagnosis. We've got to keep it wide enough to say, get the full vital signs, get a full assessment, do your scene size up. From that point, then we can start to create that differential. But that's where, the idea of, inserting these patients into single protocols too early can be troublesome. Because if we insert them into a single protocol within the first 2, 3, 4 minutes, we've not created any sort of differential diagnosis. Creating a differential is tough when we're operating under protocols, because we have to pick one eventually. But that's where the resuscitation bundle, to me, is ideal, in that that's a sick patient. Maybe it's not a short of breath patient. Maybe it's not an altered mental status patient. Maybe it's not a heat stroke patient. Maybe it's not an AFib patient yet. But we still need access. We still need positioning. We still need monitoring. We still need full vitals with temp and waveform capnography. We need to consider our foundational pieces, our chin lift jaw thrust, our NP airway, our OP airway. Have pushed those out and ready. It's a bag of saline and a milligram of epi for all my bean counters out there that watch over my budgets. I'm sacrificing 100 bags and milligrams of epi with our sick patients. If we don't need it, great. But if we have it out and ready, we should be prepared, proactive and not reactive. I feel like we can apply that resuscitation bundle without a clear diagnosis. Fluids are going to require us to think a little bit. The waveform capnography can push us towards hypoventilation versus obstructive lung disease. Our exam is going to plug in some pieces. If we hear some wheezing and we see a shark fin and the patient's tripoding, well, then we need to move towards bronchodilation. And that helps take us to a protocol. In your patient, for example, if we start with access, we start with an altered tachycardic patient, and we position appropriately, full monitoring, full vital signs, that temp comes out in there. And you don't have to put it into a protocol, an altered mental status or a narrow complex tachycardia or a dyspneic or whatever protocol you're putting it into. You don't have to put it into that protocol until you've got the patient into resuscitation mode. I think it helps us prevent that premature closure, and it also allows us to see, just like you said, how the patient responds.
And I like how you're talking about, medics put themselves into a protocol, because now you're talking about mindset stuff. It's just a mental model. I mean, it's a sheet of paper that's like, you've got a model for this type of patient. When we see AFib, very often we think, okay, this is the AFib algorithm, when in reality, the AFib's just Tyler Christoffoli calls it the innocent bystander. The AFib is just always there every day. And today it's tachycardic because they need to be in this other protocol.
If you had a patient with a heart rate of 80 on their regular everyday walk around the neighborhood and they get sick, their heart rate's going to go to 120. We talk about vital signs being vital all day, every day. So if they're in rate-controlled AFib and they're on Coumadin, and I see so many of these where we see Coumadin, we see metoprolol, we see amiodarone on their oral med list, and now they're tachycardic to 125, we have to start that like we would start a sinus tach patient. Mm-hmm. That tachycardia may be the cause of their symptoms, but it also may be the result of their illness. And more than likely, it is just an effect and not a cause. So if it's an effect, what is the cause? And that's where our net has to be wide. We can't close into that single narrow complex tachycardia protocol too quickly. We may end up in there. That's fine. Mm-hmm. We just have to make sure we keep the other ones open as well.
It's bread and butter. It's core curriculum, but I want to say it out loud in case people don't fully, have it fully digested, that AFib can get fast, just like a sinus rhythm can get fast when there are external factors, external to the heart, right? It's just tachycardia.
It's just tachycardia for them, and their native normal day-to-day rhythm is atrial fibrillation. And their long-standing atrial fibrillation, for whatever electrical reason, a lot of times folks fail ablation, they fail cardioversion, and they end up on rate control medication with anticoagulation. So they are on metoprolol, they're on sotalol, they're on amiodarone, or combinations of those calcium channel blockers, beta blockers that are out there. There's numerous ways to attack that. That's outside of my wheelhouse, but you'll see repeating in those med lists. And I've talked before about being a med list detective. The med list can help us determine what the patient's medical problems are. We can see those medications and be smart enough to know, hey, there's metoprolol there. That means they've either got some rate control, or they've got some hypertension, or they got a little of both. So then you add on Coumadin or warfarin or one of the direct oral anticoagulants. You end up with Xarelto or Eliquis. Get me into rivaroxaban and apixaban, and I start to swallow my tongue. But when you see those anticoagulants plus calcium channel blockers, beta blockers, amiodarone, we should think this patient's in long-standing AFib. So that means exactly what you said. When they go for their walk on a Tuesday and their heart rate's 82, it's an irregular 82. That's their normal state of being. So that's right. If they get a PE, if they get a pneumonia, they're going to get tachycardic with atrial fibrillation. So they're going to have rapid atrial fibrillation or rapid flutter. It's probably worth, on the topic of kind of core curriculum, to mention the other rapid neurocomplex tachycardias for a second. Just for purposes of the discussion, we've talked pretty specifically about rapid AFib, rapid AFlutter. But when we use the term supraventricular tachycardia, that really encompasses all neurocomplex tachycardias. And that's a fairly long list, and I won't make it as long as it can be, but that's sinus tach, that's multifocal atrial tachycardia, that's the AFibs and the flutters, and that's what we tend to call, on a day-to-day sort of working basis, SVT, which for the most part is AV-NRT or AV-RT. I don't want to go too far down that rabbit hole because honestly, I'm not an expert in neurocomplex tachycardias. There are a lot of smarter folks out there. Check out Life in the Fast Lane if you really want to dig into neurocomplex tachycardias. I prefer to try to keep it in a logical working format. I am not an electrophysiologist or even an emergency medicine EKG expert at all. There's a laundry list of tachycardias that are neurocomplex beyond AFib, AFlutter, but those are the ones where diltiazem and rate control form the question and the topic for the discussion. There is the AVNRT, AVRT, SVTs that a lot of folks have adenosine in their protocols for. I have adenosine in the services that I work with, their protocols as well. Those patients, we still want to look for the same pattern. We want to look for an abrupt onset. That's much, much more typical with what we tend to call SVT and use adenosine for. We don't want to use adenosine in patients with known AFib, aflutter. It's really not terribly helpful there. It just makes them feel really crappy for a few seconds. Sometimes it can be really hard when your heat stroke was at 194. It's tough for anyone to tell where P waves are and T waves are at a rate of 194 because everything is condensed. So what I've done, I'm sure you've done in your own practice, is I've had a patient at 194 that I thought was SVT, and I've given adenosine to, and I've seen the QRS complexes slow, the pause happen, and oh, look what's there on the baseline. There's very irregular P waves. So now I see the flutter pattern or the fib pattern. So I wasn't giving that adenosine to treat AFib, aflutter. That's not the correct pathway to take. But when we're at 200, it can be tough to tell. So if you use it and you get some diagnostics from it, great. That's excellent. You should use that pause for what it is. But you then at that point, you know, hey, this is AFib, aflutter. Is it stable or unstable at that point? Do I have diltiazem in my protocol at that point? Do I think it's a primary cardiac arrhythmia at that point? And then you can use that knowledge for good. I see lots of medics, lots of emergency physicians giving adenosine to known AFib, aflutter, and there just really is, no indication to do that. So I've never had adenosine, but I've given it enough to know that patients don't like it.
Well, I'll just add on that once you've gotten to the place where you're ready to use diltiazem, just know it's going to last a while, where they can't get tachycardic if they need to be.
Yeah, I guess it's probably the time in the discussion to dive into a little bit of the literature. When I get asked a question, I felt pretty strongly about diltiazem potentially early on presenting more potential harm than long-term good. And when I talk about long-term good, we talk about long-term good within our services. We talk a lot about patient-oriented outcomes when we look at the literature, and that's morbidity and mortality, that's neuro-intact outcomes, that's intubation or not, that's ICU admission or not, decreased length of stays. Patient-oriented outcomes are ones that directly impact the patient, and then we can see as the consumer of the literature, even non-literature experts, and I put myself in that category. I try to hack my way through it. I was taught some evidence-based medicine 20 years ago or so, and I try to keep it as simple as possible and not get lost in the weeds. And that is the question they're asking, does the result directly improve the patient's well-being? And when we get into the AFib, aflutter world, we start to look at the outcomes, and the outcomes are decreased heart rate. Not that that's not important, but that's really more of a secondary outcome as opposed to a primary patient-oriented outcome from my standpoint. Because in these studies, if a patient had a rate of 145 and they decreased their rate to 95, that's positive. And I'm not saying that that's wrong. I'm just saying that, did the patient know the difference? Did it improve their hospital length of stay? Did it improve their cardiac function in 6 months? Were they able to ambulate normally a year later? It's important to know that the heart rate decreased. But I think from our standpoint as literature interpreters, it's important not to overestimate what that really means, because what comes with that? There's always risk with any medication. And just like you said, diltiazem it's not Esmolol, for example, uber short-acting beta blocker. Diltiazem lasts a little longer. So I guess it's probably time to talk a little bit about diltiazem and what it is, just from a background standpoint. It's a non-dihydropyridine calcium channel blocker. So generally the non-dihydropyridines have more rate control and less vasodilation. So they act more on nodal cardiac calcium channels as opposed to vascular calcium channels. So you're not going to get as much hypotension with diltiazem as you would amlodipine, for example, which is primarily used as an antihypertensive. For the test takers out there, I have to say it, you can all cringe and throw eggs. Vaughan Williams class 4, AV nodal blockade calcium channel blocker. There it is. It's out there and it's done. When we look at the data and the evidence for diltiazem in EMS, this was really pretty startling to me, because I have given a version of this discussion and talk a few times, but I never really dove into the data before this last couple weeks. And I was honestly shocked. I didn't think I would find much, but I found diltiazem and EMS were my search terms, and I got 7 results in PubMed. Metoprolol and EMS, I got 0 results. So there's not a ton of data. Now, I did not do a thorough lit review of emergency department data. Most of the time, I feel like emergency department data can extrapolate pretty easily to pre-hospital, but this one is one, when we've talked about this extensively, the time and the diagnostics that I have in the emergency department as an emergency physician, as opposed to if you're in the field taking care of this patient, are pretty drastically different. Do they apply in the ED EMS setting? And maybe a little, but I left out the EM data purposefully. So that was the reason behind that. Most of these, like I said, most literature looks at diltiazem positive effects as a 20% heart rate decrease or a decrease below 100. Protocols can vary here. Some protocols will limit diltiazem to heart rates greater than 150. So in that situation, if you drop from 150 to say 118, then you've got a greater than 20% block. If you drop in a different protocol, let's say that heart rate's above 110 and you go from 120 below 100, that would be considered a positive response. That's sort of where the literature starts. I thought I would find tons more out there. The first diltiazem, I learned a little bit of diltiazem history going through this. Diltiazem, up until the mid-1990s, had to be refrigerated. So it was not an EMS drug at all due to refrigeration, and we struggle taking any refrigerated drugs anywhere. There was a lyophilized form of diltiazem that was put to market in the mid-90s. So the first reports of diltiazem in the literature in EMS were in 1997. There was a case report from Evanston, Illinois, with a patient treated in the pre-hospital setting with diltiazem. This was from American Journal of Emergency Medicine. I can get you all these links so you can post them. I'll post them in the MCHD Paramedic podcast show notes as well. This was an interesting case report, looking back at it historically and thinking about what we've talked about so far. The patient had an initial blood pressure of 70 and got diltiazem pre-hospitally. And I thought, man, that's something. I don't know that that's where I would have started. I would have probably looked at mental status and perfusion and considered cardioversion in this patient. But they got diltiazem. Their heart rate was up around 200 and it decreased to 100 and the blood pressure improved. So they reported that initial case from Evanston. There was a second case series in 97 published out of Tacoma. Very little background data. It was almost written as a letter. These were both in the American Journal of Emergency Medicine. They claimed 88% efficacy, but really didn't describe it very much beyond that. So Tacoma and Evanston, Northern Chicago, those were your first 2 diltiazem EMS really case report case series in 97. So we're talking 25 years ago. Then looking at the first retrospective, kind of before and after the implementation of diltiazem study. This one came out of Delaware, and this was basically we had no diltiazem in our protocol set, and then we added it. So it was a before and after retrospective study, and it's always historically interesting to me to look back and see famous names on older papers. And this was Dr. Henry Wang out of the Annals of Emergency Medicine in 2001. So obviously gone on to much bigger and better things since 2001. This was one of Dr. Wang's early studies, and they had 70 patients, and they looked at these patients before and after the implementation of diltiazem for rapid AFib. And it worked. 80% slowed. They didn't note any hypotension, but again, they only had 70 patients. The quote in the study that was most interesting to me was diltiazem should be considered as a viable field therapy in rapid AFib. And based on the data that they have, it looked very encouraging. But you have to be honest with the fact that this was retrospective, 70 patients. Interest piquing? Sure. Further thought-provoking? Absolutely. But that was 2001, and really between 2001 and 2013, which is the next time that you see diltiazem in the EMS literature, if you looked at the implementation of diltiazem into protocols over that time period, I don't have that data, but I would assume it looks like a rocket ship slope upward, because that was sort of the time in my emergency medicine career where we really started seeing diltiazem rate control in emergency medicine. I moved to Texas in 2009. My first emergency medicine job, I took my patients primarily from MCHD medics. I had been in Indiana where pretty tight state protocols, not quite as advanced from a delegated practice forward thinking standpoint. I can remember an early shift I had in one of my emergency departments where the patient came in with atrial fibrillation and looked up on the IV pole, and there was a bag of diltiazem. And I said, where'd this patient come from? They're on a diltiazem drip. What's going on here? And the medic looked at me and said, well, coming from home. I said, well, who started the diltiazem? And I'm sure I wasn't nearly that kind. And so whoever that MCHD medic was out there, I need to apologize because I'm sure I was much less understanding and thoughtful in my tone because I was younger and definitely not as introspective and wise, I guess. Sorry out there to the medics that took that changeover for me. I had no idea that the medic would even be able to start diltiazem, let alone start it in the field. So that was probably 2009, 2010, 2011. So looking at that initial case report and the progression of the literature, that kind of makes sense. The next study came out of Western Journal of Emergency Medicine in 2013. This was a suburban New Jersey system. And this is a little bigger, 275 patients. This is where, from a literature standpoint and medical direction, risk minimization, oversight standpoint, where you start to see some cracks. And is this the right thing to do? Is it the wrong thing to do? And please don't misunderstand me here to any medical directors that are out there listening. If you have diltiazem in your service, that's your decision, and I am not throwing stones. This is just my own personal thought process, not necessarily right or wrong. If you look at this one retrospectively, they looked at 22 months. The medics in the service gave diltiazem to an average of 3 patients. So that's how much contact the medics had with the treatment. This was entirely MD oversight. It couldn't be given without MD approval. These were via ALS fly cars. So they had to have online medical director approval to give diltiazem. They had a 0.7% hypotensive rate. Sounds pretty safe. One of their quotes in the study that I thought was reasonable was in the pre-hospital setting, diltiazem is associated with a very low rate of hypotension and appears to be effective in decreasing heart rate. That's a fair statement. If you look at their 2 hypotensive episodes, this is where my fear stems from. They had a patient that was 82 years old. She had an initial heart rate of 160 and her blood pressure dropped into the 80s. Is that worth the heart rate decrease in your other 270 patients? I don't know. I think it's a personal decision. I don't know that the evidence exists there to say right or wrong. The second patient that got hypotensive was even more concerning. 56-year-old male, initial heart rate was 250. Blood pressure was 110/50. And they put the rhythm strip in the paper, and it looks like VTAC to me. In the paper, they say probably VTAC, not AFib. That's risky. I don't think that there's any argument that giving a patient with a rate of 250 and VT a nodal blocker, I'm not sure anybody out there would say that's a good idea. That's with online medical direction. 4 patients got diltiazem with heart rates less than 100. So in a little less risk standpoint, but still kind of concerning. Is there downsides to that? I think you'd have to consider that. That's where we get into considering the value of the treatment versus the potential downside. What do we gain? How bad is the side effect? How bad can bad be? And I would argue that giving a 56-year-old gentleman with a heart rate of 250 in VTAC, a nodal blocker, is about as bad as you can get from a risky standpoint. They didn't review any EKGs in this study to determine paramedic accuracy. So that wasn't a part of this study. I just think we have to consider the downside. And if we give it to a patient that it's inappropriate, what diseases are they going to have? Well, in this study, this patient had VT. That's huge. They could also have sepsis. They could have PEs. They could have dehydration. They could have DKA. When you think about those groups of patients and you give them calcium channel blockers, that's not a entirely safe medication to give. If you give a patient with COPD and obstructive lung disease a beta blocker for rate control, it's not the right patient to give a beta blocker IV to. So that's some of the concerns there. The last study, the most recent, was 2019 at a pre-hospital disaster medicine. Rodriguez and the folks at Orange County in Orlando looked at diltiazem retrospectively over a couple years, and their protocol was entirely medic driven. So this is one that's more similar to, I think, what you and I would be used to here in Texas, and that is narrow complex AFib A-flutter with rapid response and a heart rate greater than 150. EKGs were read by the medics. The protocol was initiated by medics. So this is the diltiazem protocols that I know. They looked at adverse events. They looked at clinical improvement. And their adverse events were systolic less than 90 or the need for fluids. And their clinical improvement was a decrease to less than 100 or 20% of the original. The part that I knew they would find here that I've seen in my own chart review that I think you would find in any ED if you did this study is their protocol compliance was only 66%.
So what does that mean?
That means that it was
complying with.
In the study, most of the non-compliance was given to rates less than 150. Uh-huh. So it's appropriately applying. In other words, did the patient have rapid AFib? Yes or no. Was it greater than 150? Yes or no. Mm-hmm. And this is the hard part. This is the part that I've been torn during my re-entry into EMS. I re-entered EMS about halfway through my emergency medicine career is how do we teach this? How do we teach this to medics? How do we teach this to any emergency provider? The thought process behind, is this cardiac primarily? Is this a secondary response? And if so, when is the right time to give nodal blockade? When is it not the right time? And no protocol compliance is going to be 100%. I give them total kudos for being willing to look at how accurate they were with giving the medication within the protocol. Is 66% quote okay unquote? Again, this gets into your personal risk tolerance when you're drawing up these protocols. It gets into your personal risk tolerance when you're practicing as an emergency physician. They saw clinical improvement in about 57%, so a little over half of the patients. Their adverse event rate was right at 10%, and that is systolic drop to less than 90, need for IV fluids. When they were outside the protocol, the adverse event rates increased, not surprisingly, to 18%. None of these things are definitive. They're just very thought-provoking and worth discussing. I will say that the medics in this service must have had excellent EKG training. They had Paramedic MD EKG interpretation agreement at above 90%. So another great piece in that is those medics really learned rapid AFib well and were applying appropriate EKG knowledge to their patients. They didn't see any quote-unquote malignant arrhythmias, but 2 patients got DILT in this study with wide complex rhythms, one of which had an increased heart rate and hypotension after the diltiazem administration. There was no more detail given than that, but that's that 1 in 200 that really scares me, the same 1 in 200 that existed in the Western Journal of Emergency Medicine study from 2013, where is a 20% heart rate decrease, a heart rate decrease less than 100, is that worth a 1 in 200 risk of a VT administration, WPW administration, which would be very catastrophic potentially? That's a judgment call. That's the medical director call. And in the end, we've got 600 patients here or so in the literature as a whole that I could find. And I didn't do diltiazem and pre-hospital. There may be, if you're out there and you're an expert in diltiazem and atrial tachycardias, you may have a paper out there that I missed. This was not extensive and bulletproof, but a quick PubMed search found 7 studies, about 600 to 700 patients, all of which was retrospective. So very little prospective data. And all of the endpoints in these studies were heart rate decrease and less than 100, heart rate decrease less than 20%, which is an important outcome, I would argue, is not terribly patient-oriented all the time.
This was the piece of research that Dr. Patrick wanted to make sure he mentioned before I released this episode. It's from the Prehospital Emergency Care Journal. It's entitled Prehospital Intervention Improves Outcomes for Patients Presenting in Atrial Fibrillation with Rapid Ventricular Response, released in November 2023.
Yeah, so I appreciate you allowing me to add a bit of an addendum on, Ginger. I hate to talk negatively about anyone's work. I know how hard it is to get anything through at pre-hospital emergency care. They have very, very stringent criteria. I have dealt with reviewer 1, 2, and 3 there, and it's a chore. And I know Dr. Fornage pretty darn well, but there are some issues with the paper that don't really change what we discussed initially. A couple of those, just for the listeners, first and foremost, it's a retrospective study. And so with retrospective work, biases are introduced, and those are just inherent. It wasn't a randomized, blinded, controlled trial, so the strength of evidence there is just weaker by fact.
Secondly, the data was collected during the COVID pandemic. And with any tachycardic discussion during COVID, you have to believe that some of those patients were COVID positive. And so what to do with those and how to treat those across the board today versus what we were experiencing, for instance, during the Delta wave, I'm not sure that that's an apples to apples comparison. And then the last and probably most important piece is if you look in their methods, the patients that were septic were pulled out of this analysis. As you can imagine, if you were to roll out a diltiazem protocol in an EMS system, there would be septic patients that got the medication. And I know that because we had it in our system at MCHD for years, and I reviewed those cases, and these were intelligent, sharp, involved, educated medics. And these narrow complex tachycardic patients are just very difficult sometimes to suss out whether the underlying problem is cardiac primarily or some other medical disease like we discussed in our prior discussion. I don't necessarily think that I would run and add diltiazem back into my EMS protocols based on this paper. I didn't do that. It definitely is thought generating and thought provoking, and someone out there with the framework and the structure and the funding and all the necessary parts and pieces surely needs to do more work in this area. Something prospective ideally would be really, really nice. First of all, congratulations to the folks that worked so hard on this paper. It definitely made us all stop and think and read it closely. But just for full information, and so it doesn't look like we're uninformed having the discussion, we did see this paper, but as far as changing anything that we said I said in our original discussion, I don't believe that it takes me there. So thanks for letting me sort of fill in the blank there a little bit. If you want to do some work out there and you're a research-minded person, there probably is room to add to this foundation. If you've got diltiazem in your service, there's definitely a gap here. Even at 600, have we caught that WPW yet? Mm-hmm. And that's really the sort of the ultimate catastrophe with narrow complex rate control, is giving it to a tachycardic patient with aberrancy in WPW. Mm-hmm. And that could just lead to imminent, immediate collapse. The question that I'm unable to answer, and really I don't know that anyone has the answer to, is what's the danger of leaving it alone? Mm-hmm. Are we really preventing any catastrophic endpoints, allowing the patient to ride to the hospital with some tachycardia? Are they going to feel palpitations? Potentially. But if my choice is a palpitation or potential BP drop, knowing that system-wide, in the individual patient, you're probably going to be fine. If we play the roll the dice game with nodal blockers and rapid AFib, individual medics over time are likely going to be fine. But someone is going to be in that 1 in 200, 1 in 250, 1 in 300 group that gives it to a WPW patient or a VT patient and potentially has a catastrophe. I would argue that slowing the rate potentially allows you to regain some atrial filling. Mm-hmm. And by regaining some atrial filling, maybe you regain some of that atrial kick that we're taught, that the atrial kick, depending on the patient and their physiology, may contribute 10, 15, 20% to the ejection fraction. But there's still an AFib. Mm-hmm. We don't necessarily want to convert them. Mm-hmm. Conversion happens, and we know that. But if a patient's in AFib and they've been in AFib for a week and they're off their Coumadin and their rate is 140, it may be a better idea to leave them in AFib and allow them to get anticoagulation before intentional or unintentional cardioversion. Because if they've got a left atrial clot and we cardiovert them with the calcium channel blocker, which we know happens not mm-hmm. infrequently, that risk factor has not even been discussed, was discussed minimally in any of these papers. What's the risk factor of converting someone who's not anticoagulated? And we think about that in the ED a lot. When the patient comes in and I'm going to give them diltiazem and put them on a diltiazem drip, they're getting heparin or Lovenox or Xarelto or some anticoagulant along with that. That doesn't happen in a stepwise fashion. That happens together. Mm-hmm. So there is that potential risk of, we don't know the onset here. A lot of times, patient's been feeling poorly for a week. You see a rate of 150. Is it dehydration, urosepsis, PE, DKA? Do we know the answer to that? No, I don't know the answer to that immediately. If I give them 20 of diltiazem straight away with no anticoagulation and they throw a clot, are they at any more or less risk than if I had gotten some heparin on board beforehand? Mm-hmm. I don't know that heparin's going to necessarily it's not going to work that quickly. So that may be a theoretical risk, but it's something worth discussing and thinking about.
Going back a little bit, you said that the majority of medics will be fine. I know you were talking about the patients will be fine. Part of my mission and hopes for medics is that they're not hurting themselves by hurting others, right? So like I've talked to these medics who had a sepsis patient that they didn't recognize, right? And the rate was over 150 or over 160 or whatever their protocol was, gave diltiazem, and it was not what that patient needed. Maybe the patient tolerated it fine, and maybe the outcome was fine, but they still knew that their clinical judgment, they had missed something completely. That was really hard on them.
In my brain, I have pictures of people that I've given diltiazem to and realized at minute 90 that it's sepsis. And I want to go in with a syringe. I want to connect the syringe to the luer lock, and I want to extract the diltiazem. It makes you feel awful. And there's no way to do that. We can't extract from the luer lock. We have to make the best decisions we can with the information that we have. But we also have to be honest with ourselves when we consider the paths and the points in patient care that we chose as our profession. Is it wise for the cardiologist to have diltiazem at their disposal? Sure. The cardiologists aren't meeting them in their driveway. There's nothing more in a medic as a medical director that I appreciate than insight. It's the ultimate character trait to be successful in this world, is the ability to look inwardly and look at yourself in the mirror and assess your strengths and your weaknesses. It's no EKG knowledge. It's no airway competency. It's no bravado. It's no courage in the heat of the moment. All that stuff matters. If I could have one trait in someone that's taking care of me if I'm sick, it's the ability to look inwardly and to look at your cases introspectively and honestly and try to get better for the next one. If you're not doing that, you're missing chances to learn and you're missing blind spots. There's no way around that. I wouldn't expect a medic, an emergency physician, myself, not to be bothered by that. But we have to be honest about the fact that we did that protocol choice, we did that medication choice, we performed that procedure, whatever it is, with the best information that we had. We did it with patient advocacy at heart. And if we look back and say, well, that was the wrong move, rather than drown in that was the wrong move, why was that the wrong move? What can we do in take two, which we're going to get take two most of the time. We're going to have that patient again. How can I make systems changes? How can I make personal changes, education changes, practice pattern changes to prevent that? And there's multitudes of ways to do that. From a medical direction and oversight standpoint, I decided that I can't do it. I put a diltiazem pause in my own practice until I can see results and consider a full differential. And if I'm going to do that for myself, that's the right decision for putting our medics in the right position to make those same decisions. Just take it out of the equation. That's where I've gotten to with the bottom line answer. I would love to talk with folks who feel strongly in the opposite. I think that's an interesting, place for discussion, but that's where personally I've gotten to that final answer is I don't like going back and having run reviews with medics and them feeling that sort of, I shouldn't have given diltiazem. Well, you applied the protocol perfectly. You read the EKG perfectly. You did nothing wrong by any paramedic, medical, EMS, pre-hospital assessment. You're spot on. The treatment and the idea that treatment can be applied accurately with 10 minutes of knowledge put you in that position. To me, that's a systems problem.
Right.
And that's why it doesn't exist, in our services.
I think that's well said. I kind of think in terms of systems as well. And I think a lot about how medics think. It's like we need to accept how actually all clinicians think and then build the system around that.
We all have to operate within the point in time we chose to exist in the patient care pathway. This is a piece that I struggle with because when you take diltiazem out of the protocol set, you get a host of medics that come to your office and say, you're taking away our ability to provide critical care, doc. What are you doing? You're taking away our ability to take care of these AFib patients. And then they bring me an EKG of a 160 and a patient. We could have given this patient diltiazem, doc, and now we can't. What are you doing? And it's really hard in the 1 to 200, 1 to 300 range that we're talking about here for the individual day-to-day medics to see this as a risk mitigation type decision. That takes definitely some communication. It takes involvement. It's hard to take things out of protocols. It's my least favorite thing to do, really, because I want to give medics the ability to go meet patients where they are and take care of them, whether that's aggressive airway management, whether that's mobile integrated health or community paramedicine, opiate use disorder, and all the ways that we're taking the hospital to the patient, taking the ICU to the patient. If you look at a lot of the things that we've written on and studied about and pushed forward, IV nitrates, push dose pressors, esmolol and refractory VF, these are things that come from the ICU to the ED to the patient. The act of going to the protocol and saying, diltiazem, I'm going to pluck that out because I just don't think it's safe early. It has nothing to do with paramedic skill. It has nothing to do with paramedic EKG interpretation ability. If you look at our IV nitrate protocol compliance at MCHD, we were at 95% compliant with giving the medication. If you look at the EKG compliance, in the Orange County, in the Orlando study, their EKG accuracy was 93, 94%. It's easy for that to be framed as you're taking away our treatment. You don't trust us with the treatment. This is an MD paramedic clash point, so to speak. It's not that. It's that 1 in 200 and 1 in 300 catastrophe from a systems oversight standpoint. That's a humongous part of a medical director's job as well, especially when you're in Texas and you're in a delegated practice situation. It just has to be considered.
It's so neat talking to you because when I asked you to talk about this, I actually didn't know what your protocols were.
This was, I was like, I don't know how to reply back, but I don't have it.
That was really interesting. The reason I wanted to talk about it was because I've seen it. Medics have talked to me about what they perceive as diagnostic errors, and it's hurt them. And then I get, the great opportunity to watch learners just first learning AFib and how they just hook onto that as if it were the dysrhythmia, and it is a dysrhythmia, but it is a very common, a livable dysrhythmia, right?
I would agree with Tyler. Most of the time, it's an innocent bystander.
Yeah.
Most of the time, it's an effect and not the cause is the way that I phrase it to my folks is we need to treat the causes. Mm-hmm. We need to sort out the effects and manage those. But if it's not the primary cause of the patient's presentation, that goes on the back burner or should go on the back burner for us. It's just hard because what's the first thing that you do when you arrive to the patient in the ambulance? You put them on the monitor. Mm-hmm. What's the first thing that pops up? It's the heart rate number. Mm-hmm. So when you see that number and it's 2 or 3 times normal, especially the danger zone is when you're a new learner and you've not seen 160 before. Well, all your alarm bells should go off. You're doing exactly what you're taught. You're taught to mind your vital signs and to mind your objective inputs. You're doing what you're taught. Mm-hmm. And you're applying the protocol, if it exists in your protocols, that fits that tachycardia because you've not gotten to the temp yet. Because why would you get to the temp in that patient? We got to get the monitor on. Mm-hmm. No fault there of anyone's. Mm-hmm. So that's really where this entire concept to me is a systems issue. At MCHD, we took it out. Dr. Dixon and I did, which did not go over well. It went over exactly like you would expect. Mm-hmm. This was after probably 15, 20 cases of DKAs and COPDs and sepsises and PEs that we did run reviews on where patients were potentially being harmed. When you look at these studies, really, most of the patients that had blood pressure drop, I don't want to be overstating things here. They had blood pressures dropped to the 80s and they rebounded. Mm-hmm. I would just argue over time, if you've only got 500 or 600 patients total in your data set of all that exists, we have to think about as an EMS group as a whole, if that's in every protocol for every city, everyone out there, that's going to be millions. To get some heart rate reduction, are we worth 1 or 2 or 3 or 5 or 10 of those VTs, those WPWs that we're eventually going to catch? And that's where I would argue no. We really had to do some service recovery, I think is the best way to describe it, with our crews to make sure they understood we had confidence in them. This is not a shot at anyone's capabilities or anyone's credentials or their skills. It's just the facts of where we decided to stand in the patient care process very early on. This medication, in our mind, wasn't the safest. I do believe it's really important that if you're going to change something, especially take something away, you have to meet the medics face-to-face, heart-to-heart, and tell them why. Because I don't like when someone comes and changes my access to procedures, my core competencies, sort of check boxes that I get with every emergency medicine credential list that I apply for in a hospital. It allows me to do certain things within those credentials. And I don't like when somebody comes down and says, hey, anesthesia says you can't use propofol anymore without X, Y, and Z. Well, that irks me too.
Mm-hmm.
Now, if hospital administration comes down and says, hey, here's the patient detrimental episodes that we've had. We had patient X, patient Y, and patient Z under these circumstances with propofol had these deleterious effects, and we're limiting it because we want to mitigate our risk. I may still not like it, but it sure goes a long way, goes much, much further for me understanding why those decisions were made.
I appreciate you sharing your thought process. And I think anybody who listens can grasp the sincerity of kind of your perspective. I'm wondering about this 2-hour thing. It's almost like that is the protocol. It's just that medics aren't with patients for 2 hours. And so they never get there.
That's the catch. That's where it's not a matter of can you recognize it or can you not? Can you understand the physiology or not? It's not a gut punch to anyone. It's not you're not able to do that. I mean, we've seen how this movie plays out over time. Medics can't get EKGs. Medics can't activate STEMIs. I mean, yeah, surely they can. And actually, most of the time, they probably can do it better than the emergency doctor. So it's not a matter of can you or can't you. It's just the place where you are in line. And the place that you chose as a medic is the very front of the line with the least amount of diagnostics and the least amount of time relative to the other folks. Mm-hmm. So the only reason I feel like I can do it and you can't is because I got more tools at my disposal.
And more time. During this conversation only, not in advance of this conversation, but as you've been talking, because you list off PE and heat stroke and DKA and sepsis and all these things, it started sounding like to me the treatment of AFib as the primary cause. AFib with RVR, if you suspect that's the primary cause, it's almost like a diagnosis of exclusion. You need to exclude all these other things first.
I don't think I've ever said that in a sentence form. I wish I had. When I hear people, I love it when someone sums something up that I've struggled to sum up. It makes me jealous. And it also makes me happy because I'm going to steal it. There's your theft warning, AFib with RVR. If you're in a situation where you have diltiazem at your disposal, should absolutely 110% be a diagnosis of exclusion. Period. You should ask questions specifically in your history, in your exam, in your diagnostic interpretation to rule out the potential for those other things. What do I mean by that? Well, you should have a sugar. There goes DKA. You should think about looking at the calves, asking about potential chest pain or shortness of breath, and asking about PE risk factors. No, we're not going to get a CT scan in the truck, but we surely can ask about travel and oral contraceptives and no sedentary, recent surgery, cancer history, know those PE risk factors. Sepsis, is there other illness pieces that are floating around in the history? Cough, cold for pneumonia, COVID, foul-smelling urine, urinary hesitancy, urinary frequency. Is there UTI things going on? A patient with AFib RVR shouldn't have urinary symptoms. Environmentally, scene size up. Where did you find the patient? If they're out in the heat, that should come into play. But remember, there are two types of heat strokes, and there's the exertional and there's the non-exertional that can happen in nursing home patients who are ill and can't dissipate heat and potentially are on medications that prevent them from doing that. Full set of vitals will get you there. If you get a temp in your tachycardic patients, which I would argue that goes back to your analogy of an atrial fibrillation patient that's walking around. If they run, they're now in rapid AFib. Not because they're sick from rapid AFib, but because that's their normal native rhythm. So if we see a fast rhythm, we always should get a temp. Fever can always be a contributor there. Think about sympathomimetics, and do they have cocaine, crack, meth, a sympathomimetic toxin on board? Dehydration, have you had vomiting? Have you had diarrhea? Have you been drinking normally? So sometimes it's just going to be those historical questions. And that's where that pause is of huge benefit, because if we don't feel like we have to act on that 160, it gives us time to get the temperature, which we may not normally rush to. I do that all the time in my practice where I'll have a tachycardic patient and I'm going down the PE road, I'm going down the dehydration road, and did we get a temp? 103. Then, okay, now I know where I'm going. I would agree it's a diagnosis of exclusion. In that, you have to take that list of other tachycardia causes and ask your questions, get your vitals, get your diagnostics, your COPDers. You got to listen to the lungs. You got to get your end-tidal waveform. And if it's shark fin and they're wheezing, then that may be multifocal atrial tachycardia and not AFib RVR. And the treatment squarely is bronchodilation and steroids and BiPAP for those patients. So I'm going to steal that. I love it. Thank you.
I'm glad you like it. Just listening to you, my big takeaway was a stable AFib. They have symptoms, but they are hemodynamically stable and they're in AFib. This is a patient we have time with before we start aggressively treating the rate or rhythm. And what we're doing during that time is excluding all these other pretty nasty things.
All the things that we do in all our sick patients, and those are all parts of the resuscitation bundle. If they need oxygenation, we're providing oxygenation. We want to put them in a good position. Blood pressure's borderline, make sure we have good access and consider how we're going to resuscitate from there. So it's always helpful to talk through these things. I've had this discussion in various manners 100 times, but I always feel like when I finish it, we're at least a little better, or I'm a little better organized in my thought process to try to explain to medics the question that I get that I have to answer. That's a hard one, is why no diltiazem. Hopefully I can now say, hey, you know what? You listen to podcasts. I know where you can listen to the entire digging to the absolute bedrock of this discussion. I appreciate that. This was a good combination of, I think I know how I feel on this one. I wanted to be very sensitive when you sent me the topic, and I thought, yeah, this is kind of interesting. No diltiazem, huh? It's gonna fit. I just don't want to make everybody angry. And then I thought, well, I'm going to go to the literature because I've never really done that. It's probably a duh moment for me. You should have done that. And then when I went to the literature, I'm like, and this kind of confirms everything that I thought. And then I thought, oh, step back. Are you letting the literature confirm what you already think? Are you being objective? So I read everything a second time and made some notes and feel like that I got to a more firm answer. Actually, I went to Dixon the other day and I said, hey, I never really looked at diltiazem in the literature and what's there. And we did this and we felt right about it. And we've seen less of those, those cases aren't coming across the QI/QA desk anymore. So the medics aren't out there feeling bad for treating sepsis with diltiazem, like you said. So we've accomplished what we set out to accomplish. I said, but man, after looking at the literature, I feel even more strongly. And I said, I don't want to be biased here and to go in and look for an answer and then find that. I said, but there's not much there. And what is there is open to interpretation, but I feel like there's some risk in there that I don't know that I would want to put the patients in the vicinity of, put the medics in the vicinity of, put us as our organizations in the vicinity of. So I really appreciate the opportunity to kind of the prod to look at it a little more closely.
I'm just thrilled that you had an opinion that wasn't the one I expected. And what I really wanted to talk about was like, how do we teach paramedics to navigate what to me has often seemed like seemingly impossible? I think that's kind of the outcome is for me, or this discussion, is when we ask a paramedic to give diltiazem in a 20-minute patient encounter, we are putting them in a scenario that is kind of impossible. And maybe that's why I've been so frustrated for 15 years of teaching is, I've just watched this be a constant pitfall over and over.
I don't have that much experience watching it from the EMS side, but I surely have seen it for that long. From day one of residency until now, I see it in my emergency department partners. I see it in nurses. I see it in hospitalists. You're not going to treat the heart rate, doc? I am. You're not going to give some diltiazem? That steroid's going to get you there, or that bag of fluid's going to get us there. That heart rate's going to be fixed tomorrow or the next day. And that's something I tell a lot of folks in the hospital environment is this tachycardia has evolved over 2, 3, 4, 5 days. It may take 1, 2, 3, 4 days to resolve. That's okay. If that resolution is bronchodilation or rehydration or with antibiotics or whatever it is, all those things aren't instantaneous. And that's sort of the downfall sometimes of us in emergency medicine. So we just love immediate gratification. And this is a setting where we can get that perceived immediate gratification. But does it come with risk? I would argue in this situation, the answer is yes, maybe not humongous risk, but you have to balance that between a heart rate decrease of 20%. Is that worth any risk? And are you better off just saying, you know what, this patient is mentating, this patient has a SAT of 98, and they are sitting up and talking to me and doing nothing right now is 100% reasonable. That's the hard part, especially for a learner to stomach, is that I've got to stare at this markedly abnormal vital sign that they've told me for the last 4 months is a vital sign. And now in this case, I'm not going to do anything with it. it was hard for me to teach. It was hard for me to explain why we took it away. I really think adding, for all those out there that are teaching this to their medics and still have diltiazem in their protocol, I would 100% put a diagnosis of exclusion in my protocol. I would put that in bold in my protocol. So the listeners out there steal that, because that's as succinct and as applicable as any explanation that I've heard. Is you should be able to rule out all of those other secondary causes before throwing that 20 milligrams in the syringe.